everyone. As Dr. Sarkin said, I'm Tara and I'm going to talk about this case which I saw a few months back on AMU. So it's called A Breath of Fresh Air, and I'll leave you to guess why it's called that at the end. Slide's not moving. Okay. So the patient was a 32-year-old woman who works as a senior software engineer, and she's Russian, originally from Belarus, where her family are. So the presenting complaint to ED was fever, diarrhea and vomiting, abdominal pain, and just generally feeling unwell. So it was quite a difficult history, was documented in the ED clerking, because her first language was Russian. So she'd been feeling generally unwell for 4 to 5 days, weak, fatigued, feverish, and with diarrhea and vomiting. The diarrhea had stopped yesterday, but the vomiting was still ongoing, unable to keep food down, no blood in the stools or vomit, intermittent abdominal pain, and she couldn't remember eating anything unusual recently. She had been COVID positive 2 weeks prior, and she'd had diarrhea and vomiting with that and was feverish for 2 days, but then her fever settled. And she'd been well for 5 to 6 days before the current symptoms started. She'd been in the United States for a wedding, so didn't seek any medical attention. And she flew back to the UK on the day she presented, was still feeling unwell, so came to A&E. She also had some yellow vaginal discharge. She last had unprotected sex on the 26th of June, so that was probably about 10 days before she presented, and there was some pain on that occasion. No regular partner, had had an STD check a couple of weeks back before going to the US, and her pregnancy test was negative.
Can we just get a time scale on this? Just go back a slide. So she's been in the US and had COVID. Was the COVID in the US?
The COVID was, I think, just before she went. No, she was. Yeah, it was in the US. Yeah.
Okay.
Yeah.
And then she flew in a plane that was COVID negative, or okay.
I think she was due to fly back anyway.
Okay.
I mean, she. Yeah.
Okay.
Okay. So she presented on the 5th of July, if that helps in terms of the dates that are written on here.
Okay, thank you.
So in terms of background, not much really. Past medical history of some anxiety and hypothyroidism, and drugs, sertraline and levothyroxine, not allergic to anything. She was COVID vaccinated and no recent vaccines. And as I mentioned before, she works as a senior software engineer, family in Belarus. She smokes, and she had some cannabis intake in the past. Wasn't clear from the history whether that was still ongoing, but no alcohol. So documented on the ED examination, she was lying in bed. She looked pale, but wasn't visibly jaundiced. Chest was clear, normal sort of respiratory exam. Tachycardic, but otherwise a strong pulse, normal CAT refill, normal heart sounds, and a bit hypotensive. She was febrile 38.8. She had some generalized abdominal tenderness, but no rebound or guarding bowel sounds present. Neurologically, pretty normal. And she looked a bit dry, which would fit with the hypotension and tachycardia, and no rash. So investigations done at the time, ECG, just sinus tachy, nothing on the chest x-ray, 2+ positive blood on the urine dip, but otherwise negative for infections. And then her initial bloods done in the ED, white cells normal at 6.1 and neutrophils 4.6, a bit lymphopenic at 0.8, hemoglobin slightly on the low side, and platelets 37. And then sodium slightly low, potassium low, but she'd been having some diarrhea and vomiting, creatinine 62 and albumin 29, but a raised CRP at 186 and slightly deranged liver function, including a raised bilirubin.
And on that chest x-ray, did it say there's no consolidation or no, but there is consolidation?
No, there is not. There are neither of those two.
It's a normal chest x-ray. Okay.
Normal chest x-ray, yeah. So does anyone have any thoughts or differential diagnoses at this point?
Come on, somebody. Do you want to just go back to have the slide with some numbers on it so that people can comment on those? Right. Come on, people.
Let's pick on 4 South because we saw them there before.
Oh, look, we've got Vinit's put in the comment here. Vinit's put in viral hemorrhagic fever. Vinit, do you want to unmute and tell us why you thought that? There were a number of issues.
I think it was mainly because of the thrombocytopenia and the fever and the travel history. But we appreciate America is not contagious for viral hemorrhagic.
Okay, what's the blood film done? Yeah, America's not a typical place, but yeah. Look, what's the blood film done?
Later.
Oh, you're jumping ahead there. Okay. And then 4 South are refusing to answer because they know the answer.
But some really good thoughts there, I think. Everyone's excellent. I mean, maybe more than just diarrhea, right?
I mean, mainly, I hope people, anybody else, I want some more comments, guys. There's sepsis because the CRP's up, maybe. We haven't got a source. And common sources of sepsis, let's hear some. Remind me how old the patient is.
32.
32. Okay, we've got malaria.
It's good thoughts.
Because the platelets are low. So sepsis, apparently. Oh, and then we've got thrombocytopenic purpura. Because the liver function, I suppose, and the platelets again. Okay.
I think we've got a really good differential there. So
yeah, thank you. Yes.
Move on. How do I make that go again? So the clerking from the initial medical, the impression from the initial medical clerking was gastroenteritis because of the sort of diarrhea, vomiting, query cause, maybe E. coli, and the low platelets, unclear cause, need to rule out hemolytic uremic syndrome. That was the medical clerking impression. And then the patient was discussed with haematology, who felt that the clinical picture didn't suggest HUS, particularly given the normal renal function, and advised at that point a blood film, repeat FBC, and send off various sort of hemolysis screens, do stool cultures, blood cultures. They were happy to treat with antibiotics and just aim for platelets over 20. So further blood test results, HIV negative for hepatitis, negative stool and blood, reticulocytes were raised, LDH was raised, the HB by now, I think this is a day or two, I think a day later, had dropped to 82, and the white cells had dropped further, and she had mildly deranged PT, so mildly deranged clotting. So then on the post-take ward round, the issues are just sort of summarised there. I won't go through them all. You can read them. And further collateral from the patient on the post-take ward round, denied any vaginal discharge or bleeding or abdominal pain currently. She did have a cough, not aware of having HIV or hepatitis. This is before the test results were back. Doesn't drink alcohol. Confirms that she got better after the COVID infection, but then got worse again and hadn't eaten anything unusual. So the impression from the post-take ward round was viral or bacterial gastroenteritis. So she was given IV fluids and potassium replacement and started on antibiotics, anti-sickness and paracetamol. And then approximately 48 hours after admission, I was on night cover and was asked to see the patient because she'd had reported some blood in the urine. So on review, the urine in the bowl was sort of brown with a fairly large clot. There were also then some streaks of blood in the pad. And before this, the urine had been clear, and she wasn't due her next period until 7 days' time. No bleeding from anywhere else or before admission. And she was still tender suprapubically to palpation. And she said she'd been having some brownish vaginal discharge. So had a look at her bloods and noted the low hemoglobin and platelets, and the discussion with haematology. Iron, B12 and folate were fine. And then she had this rising LDH and reticulocyte counts and a high bilirubin. Blood film wasn't back yet, and noted that hepatitis, screen and HIV were already done and negative. So any further thoughts at this point, and also what is missing?
And when you say what's missing, do you mean from the
What's
history?
missing either, yeah, from the history really.
And the Prof. Mirren's put unusual drug history, which is a good question. Were they taking any over-the-counter medications or anything else?
Or herbs or so-called homeopathic stuff?
Yeah, I'm not sure that that was documented at this stage.
And that's always a really good question to ask, especially when we have to recognize in a population that are vaccine hesitant, that they often take other herbs and antifungal agents that we perhaps wouldn't normally see.
Yeah, she had had 3 COVID vaccines though. She was not
True.
like anti-vax or anything. Any symptoms of UTI? Well, she'd had a negative urine dip. She'd had the 2+ blood in the urine dip, and she was tender suprapubically. So, I mean, UTI was definitely a differential, along with maybe some sort of STD, also, you know, pelvic inflammatory or something was definitely in the thoughts.
And the blood, it was a clot there, because that's a lot of blood. Did you see a clot?
Yeah, it was a clot.
Okay. So there's hemorrhage going on. So and we know her platelets are down. I didn't see a PT or a PTTK.
Yes,
There was a
yeah.
PT and it was deranged,
Prolonged,
I think.
Okay.
Yeah, mildly deranged.
Okay. Oh, yeah. Yeah. And
Any other thoughts about what could be missing from the history?
you've given us the travel history.
Do we have a travel history? Well, all we knew from the ED clerking was that she'd flown back from the US.
So I think we have to say it's a travel history, isn't it, Tara?
Yeah, so there wasn't a full travel history.
Okay, so Victoria wants to know about family history. Oh, here they come. Pregnancy test,
It was
unwell
negative.
contacts.
It was negative, the pregnancy. Unwell contacts, I don't think so, but I can't remember. PV discharge.
Any bites?
Yeah, she had some bites. No, she didn't have joint pain. No, nothing unusual in terms of food. I hope everyone can see the questions, actually. That was, did she have any?
Yeah, they can. They can if they click on chat. Yes, a reference device.
Okay, to carry on. So travel history. So
that's not fair.
So then I asked her more about, you know, recent travel, and she had indeed been to the US and Trinidad and Angola, and she worked backwards very slowly from, yes, I've just come back from the US and talked about that, and then Trinidad and, you know, etc. But then it turned out she'd been in Angola for just over a week for a wedding. And on questioning, she hadn't taken her malaria pills because they made her vomit when she took them in the past. She just used the spray. And yes, she was bitten by mosquitoes, which is where the bites thing comes from. And then she'd started to feel unwell 10 days later when she was in Seattle. She'd been in Trinidad for a week before that. So at this point, the top differential was malaria, but also with the PV bleeding, as someone I think mentioned earlier, viral hemorrhagic fever, of which Ebola is one type. So there was no Ebola, there's no history of Ebola in Angola, but it was known for a different type of viral hemorrhagic fever called Marburg. And she did have quite a few of the symptoms of that. So the fever, the watery diarrhea, and, you know, bleeding, including it can be PV bleeding. Other differentials, it could just be her menstrual period arriving 7 days early, or it could be a UTI or STI.
Or hemorrhage, or just hemorrhage.
Or just, yeah. So plan was for an urgent malaria screen, discussed with ID, urine MCS and vaginal swabs. And then ID got quite excited and said she needs a side room and level 2 PPE until she'd been seen in case it is viral hemorrhagic fever, and obviously do urgent malaria screen. And then ID came to see her and took a further ID type collateral. So no interactions with unusual animals, was bitten by a dog, a puppy, which hadn't, I think that's the puppy hadn't received any vaccines, but it wasn't a penetrating wound. And she hadn't been in caves or mines or been in contact with monkeys, bats or antelopes, no tick bites, no swimming in fresh water, and she is a pescatarian. So their impression was malaria was the top differential, but need to kind of rule out other causes. And actually the ID consultant felt that the bleeding was probably in just an early period because of her being unwell, rather than suggestive of viral hemorrhagic fever. And so given that malaria was really the top based on the history, that was felt to be less likely. So then she had presumed malaria severity risk assessment done, and those you can see the categories that they cover for that.
I did not do a blood film. I mean, that's what they do in Africa. They do a quick blood film and they can look and see them. What,
for the malaria?
Yeah.
Well, she did then have a malaria screen, but she hadn't had one at this until this point.
Yeah.
So just to give a context, this is happening overnight.
Yeah, this was at like 7 a.m. in the morning.
Oh, I see. Okay.
But the PV bleeding started. Yeah. So then the malaria test came back extremely positive with a parasitemia of 32%. And as Rob will tell us later, severe malaria is anything over 2%. So it was extremely high. And she was started on IV artesunate. And then for anyone with severe malaria with a high parasitemia, they should be escalated to ITU because they can deteriorate very quickly. So she spent, I think, 5 days on ITU, had a few bits of problems, a bit of melena, a bit of a Mallory-Weiss tear, HB dropped, and then came back down to the ward. So she still had a low HB at that stage, and was given transfusion. And then she was discharged, followed up in SDEC by the ID team in 4 days' time. She was doing well and her bloods were improving. And then another follow-up appointment in 10 days, at which point she was discharged and just told to avoid contact sports because of the malaria-related splenomegaly for 6 weeks. And then she was followed up by the critical illness, because she'd been on ITU, she was followed up a month later by their team. And I just thought it was quite interesting, the documentation that she'd been having a lot of flashbacks and sort of panic attacks and psychological upset because of this period that she spent on ITU. And you can see what those are sort of written in her own words there.
Can I ask, Doris is on the chat. Doris, does this come up frequently? Sorry, to say Dr. Doberens in your post-ITU follow-up clinics?
Sorry, it does. Yeah, these are common things people comment on. Yeah, I think it's partly because if they're sort of fully awake or sort of half sedated, they find the things we need to do and the things that go on around them. If they're awake and they see other people's distressing things, yeah, it can be quite psychologically difficult, and it can cause post-traumatic stress.
Yeah.
Thank you. That's really helpful. I think something we should all be aware of in terms of the complications of sending someone to ITU, although often it saves their life.
Mm.
So I'm going to hand over to Rob at this point to tell us a bit more about malaria and viral hemorrhagic fever.
Hello. Thanks, Tara. That was brilliant. I thought it was a really kind of nice case. So I just wanted to pick up a few bits to just talk through. And the first thing I want to actually chat about is the travel history, partly because those of you who've been on Take With Me know I'm absolutely evangelical about travel histories in everybody. And I think that actually the things that get focused on in travel histories frequently are not necessarily the things that are highest value. And there is a kind of straightforward way of doing a travel history where you don't have to get absolutely every story of everything that's ever happened to them everywhere they've ever been, and just focus on the relevant bits. It could be very, very quick. There was a concern in this patient about viral hemorrhagic fever, and the HCID ADTP algorithm that everybody follows is a little bit scary. And I know that there are going to be a number of medical registrars on this call. And I thought that just spending 5 minutes going through the kind of major causes of viral hemorrhagic fever and how to not be scared by the HCID algorithm would actually be really valuable, because it's one thing kind of knowing that it's there. It's another thing actually having looked at it and understanding how to use it. And I just want to demystify it a bit because it's actually quite straightforward. And then finally, I want to talk about malaria, because malaria is a particular interest of mine. I've done quite a lot of it in the past when I was at AN other institution. So next slide, please, Tara. I'm just going to channel my inner Chris Whitty there. So the travel history. I want to do this as a straw poll, actually. Who needs one? Which medical clerking inpatient, which people you see on the medical take need a travel history?
So Andy said we can send the sample.
Put some answers in the chat.
Do you have some options, then Cream could create a poll?
Okay. How about people with fevers, people with diarrheas, people with shortness of breath, or everybody?
Yeah. So okay. And
Say people with fever.
obviously the thing which we
I suspect I know the answers. I'm typing this out. Well, in fact, I'm just gonna do the everyone.
So I just need the details of the patient so I can.
But votes are coming in. There's 21 people on the thing, and 7 have already voted. Let's keep voting. Let's have a look. So in the chat, A, fever, B, diarrhea, E, everyone. Okay.
I don't know what C and D were.
I mean, I think probably people have got where I'm going with this, to be honest. Well, have we got the? Oh, very good, excellent. Some people put C, and we don't know what C is. That's great. So yeah, I would say that everybody who's coming in on a medical take needs a travel history, because it doesn't take very long. And actually, if you think about what proportion of the medical take are people with acute infections, then everybody with an acute infection needs a travel history, and a whole number of other non-infectious things where you probably want to know if they've been on a long haul flight, if they come in with chest pain and hemoptysis. So I think that given it's really, really quick, and you can just say, and in terms of how far back to go, the kind of standards that you'll see in kind of infectious diseases admissions is going back 6 months. So you can just say the simple line, have you traveled anywhere abroad in the last 6 months? Most people are going to say no, but especially in this kind of post-COVID era where we're not used to people traveling as much anymore, I think that it's actually really, really valuable. And it's not always the people you think have traveled. Like, you can get dialysis abroad now. Being more elderly is no reason why you haven't been somewhere exotic in the last few months. So it's worth asking everybody. And I think
it's worth saying in this case, they did, and they got USA and didn't get Luanda.
Yeah, no, exactly. So sometimes it can be misleading. It was good that Tara actually made the diagnosis by going back.
To be fair, though, you have to ask the specific questions. I would never think to ask, have you been bitten by a dog recently? And that might be relevant in this case.
Yeah, that's true. I mean, you can ask. I think asking about animal bites is pretty reasonable if you get anybody with a fever, to be honest. And there are plenty of reasons why you can get a fever after a dog bite in the UK, without having to invoke worries about stuff like rabies. But anyway, the kind of point of the travel history, it kind of comes down to this thing called Parry's maxim, which if you go towards Bloomsbury, then people will spit at you all the time, which is, why does this person who went to this place at this time have these symptoms? Try and picking out all of the important bits, named after Eldred Parry, who sadly died last week. He's one of the kind of godfathers of tropical medicine. So really, why do one? The first is possibly to get the diagnosis, but actually very rarely you're going to be able to say with certainty, based just on the travel history, what the diagnosis is. I can think of maybe a couple of circumstances where that's the case. I went swimming in Lake Malawi and I've come back and I've got a rash, or I went to Kruger National Park and took a tick off me and now I've got a fever. You know, that there are a few specific scenarios where you might be able to make a diagnosis of travel history, but normally you're just trying to work out what people are at risk of. The second reason, and this is important in terms of this case, is risk stratification in terms of their potential for having something that might be dangerous to other people now, high consequence infectious diseases like the viral hemorrhagic fevers. And the third one that I don't think is really thought about as much is kind of therapeutic implications. And I've got one slide on this, basically because the rates of antimicrobial resistance for different bugs vary widely around the world. So I've got an example just to show, because even something you might have easily picked up in the UK, then your empiric therapy in the UK might not work for something that was picked up in China or the US or sub-Saharan Africa, because the amount of antibiotics that they use in the environment. Can I have the next slide, please, Tara? So the first thing obviously is place, and it's nice to know which countries, and that was kind of what was lacking from that particular, from the travel history that the ED got, was that they knew that they'd gone to the US, but really the follow-up question there should have been, have you been anywhere other than the US in the last 6 months, given that you're presenting with a fever? It's nice to know exact locations. That's not always going to be possible, especially if you're under a bit of time pressure in terms of the medical take, and especially if somebody has just come back from traveling around the world and they've gone to 30 different countries. Finding out exactly which villages they stayed in is kind of academic, but it actually, if you know roughly what kind of setting they were staying in, were they staying in a hotel in big cities, or were they staying in villages, were they staying in huts, were they camping, were they out in the bush? Those things can actually help you kind of stratify what they might be have been at risk of. I'm using multiple of these infographics from my mate Doug Fink's paper from 2018, which I highly recommend. If you're interested at all in fever and the returning traveler, it's absolutely beautiful paper just because of the quality of the illustrations, and it's a really good kind of quick reference guide if you want to know what kind of thing somebody is at risk of depending on where they've been in the world. The kind of things here that have got crosses on are the things that are much more common in those areas and should be considered as like a primary diagnosis. So, for instance, if you've been to Southeast Asia, then things like arboviruses and enteric fever are really top of the list. Okay, next slide, please. The next thing is who this person is. What did they do while they were there? Why did they travel? And a lot of people don't ask this. Did you travel because you were just going on holiday, or were you going home to visit friends and relatives? Were you actually going off to volunteer in an Ebola treatment center? These things are extremely relevant in terms of the travel history. The other thing is, once you get to why they traveled, is what they were doing there and whether or not they had specific risk factor exposures. Again, summarized really neatly in this paper from 2018. Again, can't recommend it enough in terms of as a quick reference. There are some things just to think about in terms of VHF risk, which I've listed there, which is the big one is funerals from somebody who's died of an unknown illness, which is actually a pretty common reason to go to visit friends and relatives in sub-Saharan Africa. And that's kind of important, because if they've died of something you don't know what it is, it absolutely could be the start of a new VHF outbreak you don't know about yet, and particularly exposure to healthcare, and if they've been handling bodily fluids or caring for somebody who's unwell. In terms of the other stuff, and this was, somebody brought this up when we were talking about the thing, should you take a bite history? That's actually, that's a bit difficult, because you should certainly take a bite history for stuff that isn't mosquitoes. But actually asking, did you get any mosquito bites, is actually not really very helpful, because if somebody has gone to an area with mosquitoes, they have probably been bitten. It's very difficult to say, oh, you don't report any mosquito bites, therefore you can't have malaria. Similarly, anti-malaria chemoprophylaxis, while it's brilliant at preventing people from dying of malaria, it's not actually amazing at preventing them from getting malaria, partly because compliance is somewhere between 3 and 5% for full compliance. And even if you're fully compliant, it is at best, and the best studies out there supporting it say it's 95% effective. So you can't really rule it out. The only reason why it's useful is back in the day when we didn't use artesunate to treat malaria, then you wanted to always use a drug that they weren't already on for prophylaxis in order to treat malaria if they got it while they were away. Okay. Oh yeah, similarly, bottled water history. So I see this a lot. Like, actually, just because you only drank bottled water does not mean you're not at risk of a waterborne pathogen. Partly because you don't know where that bottled water came from, and there are entire plants in certain parts of the world that will be rebottling essentially filtered tap water as bottled spring water. So you don't necessarily know anything. And getting a kind of I guess what I like to call the dodgy kebab history is also not particularly helpful, because you don't know where it depends where you are in the world. It could be that you ate only in 5-star hotels and you're still at risk of a foodborne infection. Okay, next slide. Back one, yeah. Timing is the thing that I think is generally, in my experience, not done in terms of a travel history. You see a lot of travel to Nigeria, but not actually when did you get back, which is actually probably one of the most important things when you're coming to try and make a diagnosis of somebody who's a returning traveller. The reason for this is that there are some very specific and sometimes quite hard incubation time cutoffs for certain infections. I think probably the best example is something like an arbovirus like dengue, where on this infographic it says anywhere between 2 and 14 days. 14 days is really the upper limit. Most people who've got dengue are going to be symptomatic within a week. So if somebody's come back 2 weeks ago from Southeast Asia and they've only got a fever today, the chances of them having dengue versus them having enteric fever are actually extremely low, or even malaria. This also kind of helps us inform us how far back you have to go, because I said 6 months. I think 6 months is quite a helpful cutoff to use day to day. But something like malaria, falciparum malaria, is actually pretty rare to turn up more than 3 months after you've left an at-risk area. Other malarias can be up to a year later. So even if somebody's got an extensive travel history, haven't traveled for 9 months, it's still probably worth doing a malaria film if they're febrile. And relating that to the onset of symptoms is also really, really useful. Again, I refer you back to this excellent paper with all of its beautiful pictures. Next slide, please, Tara. This is the HCID ACDP algorithm that's used throughout the UK for the kind of risk assessment of viral hemorrhagic fever. And it looks really scary the first time you're looking at it, especially if you're looking at it at 2 in the morning. You've never looked at it before, and A&E's just called you about somebody who's got a fever and they've just come back from rural Uganda where there's an Ebola outbreak at the moment. But actually, it's relatively straightforward. And I just want to demystify it just by going through the 4 major causes of VHF and how the questions at the top, which are really the risk stratification questions, kind of link into how you use this algorithm. Can I have the next slide, please? So the first thing, and this is where timing is so important, we basically say that 21 days is as long as you can have an incubation period for viral hemorrhagic fever. There are some of them, like Lassa, where it might be you get the occasional patient that's a little bit longer than that. But for the purposes of infection control, given the fact that these are rare diseases, it is perfectly reasonable to say somebody's come back from a VHF endemic country 28 days, 35 days ago. Actually, if they've only got their fever today, the chances are that this is not going to be a VHF. There are 4 high-risk VHFs that we worry about: Ebola and Marburg, which basically go together because they're very similar viruses. They've got the same reservoir. Lassa, which is probably the commonest one, and CCHF, which is the most widespread one. CCHF stands for Crimea Congo hemorrhagic fever. And this lovely, beautiful picture is a picture of a filovirus, in this case, Ebola. Next slide, please. So Lassa is probably the commonest one. It is endemic in the areas in blue on the map on the right, and it's very seasonal. So Lassa fever season is starting now. So it runs from December through to February. We've had a few Lassas in the last 20 years that have been admitted to UK hospitals and had to be transferred to the Royal Free for management in their high security unit. The most critical thing in terms of their history for Lassa is where were they staying? Because in the case of somebody who's just stayed in urban areas in a hotel, their risk of coming across the vector, which are these multi-mammate mice, which is, I've got a little picture of this little cute guy up here, is actually really, really low. These are rural mice that feed on like field crops and things like that. If, on the other hand, somebody's been living or working in a rural area which has got Lassa fever, then they're a much higher risk, because it's actually very, very common. 80% of people don't get any symptoms from it, and it's got, comparative to the other causes of hemorrhagic fever, a very low mortality. But it's something to be aware of. Just because somebody's not had exposure to bats or bushmeat, they might have been exposed to Lassa in any of those countries. Next slide, please. Ebola is the one that everybody's heard about, and Marburg is much less common, but causes much more kind of bleeding, and there's no vaccine to it, so it's potentially a little bit more scary in that way. This is a map from the PHE website, by the way, which is a great that's a great resource, especially if you're on take and you want to just check what the kind of current outbreaks are of any of these things. Then there's a nicely updated list of where there are outbreaks of Ebola and Marburg on the PHE website that you can find just by Googling. The symptoms for all of these things are basically very, very similar. People present with fevers, malaise, latitude, headache, sometimes diarrhea and vomiting. Marburg and Ebola are scary in terms of their mortality rate. Marburg's got about 50% mortality. Ebola depends on which outbreak as to what the mortality is, and the treated mortality is probably quite a lot lower than this. Ebola in the 2014 outbreak really caused much more of a diarrheal illness, which I suppose is relevant in terms of this presentation as well. Whereas Marburg seems to cause a lot more in the way of bleeding. The things to ask about in the history is, I see this person just come back from working in the Ebola treatment center. Have they been to any funerals where they don't know what the person died of? That's partly because a lot of traditional funerals involve dressing of the body and a lot of contact with the body. And actually these patients are the most kind of infectious when they have just died. So there's lots and lots of virus that they might have been exposed to. The vector is bats for both of these, and most tourists are not going to have any direct contact with bats, but they might have gone to visit caves where the bats are. So that is also kind of a bit of a red flag. In terms of outbreaks, now outbreaks are probably the most important thing to think about if you're thinking somebody might have Ebola or Marburg, is to look up on the internet where there are current outbreaks, because almost all transmission pretty much of these things into areas where they're non-endemic is in the context of somebody getting infected during an outbreak. So currently there is an outbreak in Uganda. There have been a couple of outbreaks in DRC over the course of the last couple of years as well. Next slide, please. CCHF is the one that people have heard the least about, Crimea Congo hemorrhagic fever, and it's got the most scary kind of distribution. Every country on that map that's any color other than gray has got at least the vector, and the red ones, they have at least one case of CCHF per year. This is quite scary. It's transmitted by ticks, they're animal ticks, and you can also get it through animal slaughter or eating bushmeat. So when I say animal slaughter, there was a case admitted to the UK about 9 years ago, where a gentleman from Central Asia had been to a wedding and there was ritual slaughter of a lamb. He got sprayed with the blood and then he got CCHF. CCHF can mimic a meningoencephalitis. People often have a kind of headache, photophobia, petechial rash kind of picture, and often have a bit of confusion as well. So it's something to think about. If you're seeing somebody with a severe infection who's traveled to any of these places, it's worth asking. There was an outbreak of this earlier on this year in Iraq in terms of like the current epidemiology. Next page, please. So if we then break down these questions that you might just about be able to see on the screen, the first question is really about all VHS. Is there an outbreak where they've been, or have they lived or worked in somewhere where Lassa fever is? You don't have to have an outbreak for you to be at risk of Lassa. Then there are specific ones. First off for Ebola virus and Marburg virus disease, and then for CCHF, where people might report that they've crushed a tick into their skin, they've been bitten by a tick in any of those areas where it's common. Then if you go down the algorithm, do they have a fever, and have they had a fever in the last 24 hours? If yes, have they come back within the last 21 days? If yes, have they answered yes to any of these questions? If that's the case, you just immediately call us. Yeah, we'll call any member of the infection team, and we'll be able to take it from there. If no, then there's more specific questions about whether or not they were exposed, pardon me, exposed to any kind of bodily fluids of anybody who has a VHF, and then if yes, then it's the same again. Finally, if they say no to all of the questions, if they've got active bleeding, you still should discuss it, because it's always possible that they haven't reported the right risk factor exposure in this case. Can I have the next slide, please? Practically, it's just important to get a decent travel history, especially if somebody who's very unwell with a fever who's come back from sub-Saharan Africa, and follow the algorithm that is on the intranet. If you just search HCID on the Imperial intranet, it's the first result, and you can check outbreaks on the web, either from the PHE website or this thing called ProMed Mail, which is open source, and you can see maps of where outbreaks are at the moment. And if you're in any doubt at all, like there's somebody around 24/7 from infectious diseases or microbiology who'll be able to help. Next page, please. Just before we finish talking about travel history and VHF, I just wanted to point this out. This comes back to the fact that antimicrobial resistance is different worldwide. So if somebody comes in with a pneumococcal pneumonia and they've just come from South Africa, it might not be a good idea to treat them with penicillin or amoxicillin to start off with, because it's 80% chance they're going to be resistant. Again, underscoring that even if they've not got a tropical infection, travel history is actually really important. Next slide, please.
What, can I ask you?
Yeah.
The resistance in the UK? I guess I should know that. I don't know.
I hold on, I've got clever people next to me. Anna, what's the pneumococcal resistance in the UK to penicillin, do you think? Negligible. So let's talk about malaria. Malaria is still a key cause of imported morbidity and mortality. Normally when we're talking about malaria that causes severe disease, we're talking about Plasmodium falciparum. These other ones are the ones that can cause malaria. They're much, much less common. They're much less severe in general, with the exception of Plasmodium nelsai, which is pretty much, thank you, which is pretty much isolated to Southeast Asia. And Indonesia, and Plasmodium simium, which is the newest malaria that's been identified as really the cause of most malaria in Brazil. There are still about 2,000 cases every year. And if you have a look at this graph, then actually, despite the fact that malaria incidence worldwide has dropped by nearly a third in the last 25 years, then we haven't really seen much change in the amount of imported malaria. There are anywhere between 3 to 16 deaths every year in the UK from malaria. And the biggest things that correlate with death are either delay to getting effective antimalarials or age. So age over 60 is a big risk factor for dying of malaria. Unfortunately, we had 3 deaths due to malaria during the first wave of COVID. That was because of lockdown, essentially, and the advice given that if you had a fever, then you should not leave your home. So people who had traveled and didn't have COVID, but did have malaria, didn't seek help, and unfortunately had delayed treatment and died. This map is the most up-to-date map from the WHO 2022 report, kind of showing where you find malaria, and it's essentially almost all malaria we see in the UK is from sub-Saharan Africa, and almost all of that is from West Africa. It's very rare to see imported malaria from South Asia or even Southeast Asia anymore, partly because of really, really good control efforts in those regions. Next slide, please. Okay, so clinical features of presentation, basically it can look like anything, which I'm sure everybody here knows. The only kind of common feature is fever, but as I've tried to illustrate with this graph, which is 400 malaria patients that I looked at Hospital for Tropical Diseases a few years ago, actually the majority of patients actually do have a temperature on admission of less than 38. They just have a history of fever. So just because somebody's not got a fever at the front door does not necessarily mean that they don't have malaria. Diarrhea is really common in people who've got malaria, and that's why in cases of delayed diagnosis, they're often treated as a kind of acute gastroenteritis. But really, it can manifest as anything. And cerebral malaria can look like anything. This chap on the right has got a case of cerebral malaria. It can present as coma, focal neurology, seizures, anything. And they might present with other complications like acute kidney injury or acute respiratory distress syndrome. But both of those complications tend to be a few more days into the illness. And normally you pick them up by then. Next slide, please. As mentioned, this is like a really nice teaching case of malaria because there are lots of features about it that are really typical. The first is a normal white cell count, which you would have thought that's abnormal because it's an infection. Surely the white cells go up. They don't. And it's not the only cause of a fever in a returning traveler with a normal white cell count. I've listed them below. Enteric fever always has a normal white cell count as well. But that plus low platelets really should increase your index of suspicion for malaria in this case. Often they've got quite a mild anemia due to hemolysis early on, and they might well have an acute kidney injury because of the diarrhea or because of direct effect of the parasite on the kidneys. You often see a mild transaminitis, but this comes with a bit of a health warning. If you start seeing a transaminitis that's in the thousands, you need to think about some other causes of that. It's very rare for malaria to cause a really severe transaminitis. And if you're seeing a transaminitis of like over 1,000, you've got to be thinking viral hepatitis, or actually you've got to be thinking viral hemorrhagic fever, because things like Lassa will frequently put your ALT up into the kind of 2,000-3,000s. Often the bilirubin will be up, but that's normally just due to hemolysis, and CRP will be up, all of which was the case in this particular patient. Next one. The complications are all due to this this sequestration phenomenon, which Plasmodium falciparum uses to try and escape from splenic clearance. So it makes the red cells sticky. They stick in postcapillary venules, and then you get localized inflammation. You get perivascular hemorrhage and things like that. So the kind of classic organs in adults where this occurs is in the brain, so cerebral malaria, renal failure. So that used to be called black water fever because people get dark urine because of all the hemolysis they're getting, and they get an acute kidney injury. Lactic acidosis tuberculosis is probably one of the commonest complications of malaria, and it is associated with a kind of more stormy disease course, and it's quite a good early marker of, is this person going to get much sicker over the course of the next few days and weeks. Okay, and then the other ones are listed, and you've probably come across them before. ARDS is very rare in malaria. It's normally iatrogenic. It's normally because it's normally in the recovery phase. It's because people have been given too much in the way of fluids. Next page. So I realize we're running short of time. Oh, right. So I didn't realize that yes, so this is just a little diagram showing these parasitized red cells sticking into all of these different areas. This lady probably did have a degree of bone marrow suppression, given the fact that all of her blood counts dropped as part of her presentation, and that's probably due to the malaria as well. Next slide. So the diagnosis is important, and it's important because it's one of these things that's a treatable, life-threatening cause of pathology that's imported, but you have to do the right test in order to pick it up. It's not like typhoid, where everybody with a fever who's sufficiently unwell is going to get a blood culture and you'll pick up the typhoid that way. You have to think about malaria in order to test for it. So the test that we do now is either it's a combination, which is a rapid diagnostic test. It's the same concept as a lateral flow test for COVID, which looks for 2 plasmodium antigens. Like there's one called plasmodium lactic dehydrogenase, which is found in all plasmodium, and one called plasmodium HRP2, which is only found in falciparum. Now, this is really interesting because, first off, these are very easy to use, and they're so easy to use that we kind of converted how we treated malaria in sub-Saharan Africa as a result of them, because rather than just somebody with a fever going to a clinic and just getting given antimalarials because blood films were not available, then actually we now started saying, well, we'll do a quick RDT, and then if that's positive, then you can have your antimalarials. That's actually exerted a selection pressure on Plasmodium falciparum, so it started deleting the HRP2 because it gives it a selective advantage because it doesn't get treated because it's not picked up by the lateral flow test. The gold standard is a thick and thin blood film, which is problematic if you're not looking at plenty of them, which is why we do the RDT as well. Next slide, please. Sorry, I'm aware that we're running a little bit low on time. Next slide. The RDT test is available in the lab. They should be able to do it first. It only takes about 15 minutes for them to get the blood out and actually run it. It should be very, very quick. These are some examples of thick and thin blood films. The thick film is on the left. And it is basically loads of layers of red cells on top of each other, so you can visualize as many red cells as possible, and it's just a kind of yes, no, is there malaria? The thin film allows you to estimate parasitemia and also identify which parasite is causing the infection. If you're not used to looking at these, or if the biomedical scientist isn't used to looking at these, frequently people will be reported as having mixed infection, which means you treat them as if they've got falciparum malaria until somebody else has a look at the blood film. Next slide, please. So as Tara mentioned, in terms of severity, severe is anything with parasitemia of 2% or greater, or if they've got schizonts on their blood film. Because falciparum malaria hides away in the organs because of the sequestration phenomena, you shouldn't see schizonts, which are kind of the mature infected red cells ready to burst, anywhere near the peripheral blood, because they should all be in the tissues. If you see them in the peripheral blood, that means you've got loads of parasites just ready to come out. So you have to treat them as if they're severe. Complicated malaria is anything that any complications at any parasitemia. So if you've got severe or complicated malaria, you treat it parenterally. So with IV artesunate. Next slide, please. So IV artesunate, we used to use quinine and or another agent. If for whatever reason you cannot access IV artesunate, then the priority is giving something intravenously. So give quinine. Quinine we've abandoned because it's actually less good. It's also got horrible side effects. It's a class 1 antiarrhythmic drug, and it causes hypoglycemia. Uncomplicated non-severe falciparum malaria can be just treated orally with 6 doses of Riomet, which is an artemisinin combination therapy. Again, we used to use oral quinine with another agent, but that's largely gone by the wayside now. These are all in the drugs cupboard in all of the respective A&Es across all the respective imperial sites, and the time to treatment is crucial, and you can increase absorption of the Riomet by taking it with a fatty meal. In general, the advice is don't treat empirically, because really you should be able to get a malaria test back within an hour. And actually there are other causes of fever in a returning traveller. In this case, I believe this woman was treated empirically before we had the malaria result back. I think that's completely defensible because there's been such a massive delay between her presentation and her diagnosis that you just wanted to get something into her as quickly as possible. Next slide, please. What about other care? You've got to be really careful with fluids. And it's really interesting. Many more people now get fluids just as kind of a default in A&E. And actually, fluids in malaria can be really dangerous because they can go into fluid overload really, really quickly. So just be careful. If they are clinically dehydrated, then some IV fluids is fine, but you need to be continually reassessing that you're not going to be overloading them. If they are cold, if they look like they've got gram-negative sepsis, then just consider the fact that actually a lot of non-typhoidal salmonella bacteremias in returning travelers occur in people who've got malaria. So if in doubt, then you can just give them a shot of ceftriaxone. It used to be called algid malaria. And if they're just not looking quite right and they've got a low blood pressure and a high white count and things, it's probably worth doing. I would have an incredibly low threshold for sending somebody with malaria to ITU because they can deteriorate, not in a matter of hours, but really in a matter of kind of 20, 30 minutes, especially with a parasitemia like 32%, which is very high. Next page. This is the last slide. So in terms of the follow-up, you always need to follow up malarias. And if you've had a parasitemia like this woman had of like 32%, then you've got to accept the fact that every single cell that was parasitized during that person's infection, even though you killed all of the parasites, the spleen will then clear all of those red cells. So she is going to lose 32% of her hemoglobin or proper hemoglobin over the course of the next few weeks as the spleen eats up all the damaged red cells. This is called post-artesunate delayed hemolysis syndrome, and it's very, very, very common. So we would historically have actually done follow-up full blood counts weekly for at least 4 weeks on somebody like this. It depends on the parasitemia. If it's only like 5%, you might be able to get away with just doing one at 2 weeks or one at 3 or 4 weeks or something like that. But actually active follow-up, even after you let them go home, is pretty important. Anyway, that's all I've got to say. Sorry, we're running dangerously close to time because I tried to fit too much in.
Actually, Rob, I think everyone has been so fascinated by your talk. It's been an amazing talk with Tara. Dr. Schofield's asked a really good question. Is the rapid diagnostic test available in the ED department?
No, but that's a great idea, isn't it? No, at the moment, it still has to go to the lab.
And can I ask, in the old days, we were told you had to do 3 thick and thin films. Do we still have to do 3 thick and thin?
There is no data supporting 3 thick or thin films at all. It really depends on how good the lab is. So if the lab is the lab at HTD, then 1 film is enough to rule out malaria. In the case where you've got a rapid diagnostic test that's negative as well as a thick and thin film, I'd be pretty comfortable saying that unless you've got a really high clinical suspicion, like they've got all of the right other features for malaria, like they've got low platelets, they've got normal white count, they've just got back from Abuja or something like that, then I would probably be happy to say that person almost certainly does not have malaria, and you don't necessarily need to repeat the film the following day. But there's very little data saying that 3 films is really better than 1.
Okay, brilliant. We have run out of time. So I just want to say thank you again to Dr. Lever and Dr. Latimer for giving such an amazing talk, perhaps an ID inspiring talk for those of you who are on the fence of what you want to do.
Just before you go, there's a question from Connor.
Oh.
Out of morbid interest, what happens when the call comes through and it's actually VHF positive?
So I'll talk you through basically what happens if you hit the kind of high probability of VHF and you call infectious diseases. The infectious diseases registrar or consultant on call will discuss it amongst themselves, and if they think it's still think it's high probability, that person stays in isolation, and then they call the imported fever service, which is a 24-hour helpline for infectious diseases clinicians, basically, that's based either at HTD or at Liverpool, depending on the week. They rotate it. If they will then discuss with the rare and imported pathogens laboratory at Porton Down, who, if they agree, will then arrange for testing. And at that stage, that patient will be kept in level 2 PPE. You assume that they've got a hemorrhagic fever until proven otherwise. If it is positive, then it's a secure ambulance over to the Royal Free with all the kind of containment measures in place, basically.
Thank you. Great. Thank you very much.